This second lecture focuses specifically on the transition the baby makes from one watery environment to another, then into air, and the transition he makes to air breathing. In 1996, Paul Johnson, a consultant physiologist at John Radcliffe Hospital in Oxford, wrote what has become a classic paper, Birth Underwater, To Breathe or Not to Breathe. I've put it in your readings. Most of his research has been on fetal and postnatal neurodevelopment and respiratory control. He explains that the fetal breathing movements in pregnancy, which are crucial to fetal lung growth and development, occur about 40% of the time in the near-term pregnancy, but there is minimal fluid entry past the larynx. This is not about practicing for subsequent air breathing, as is often said. Johnson writes about it as obstructed at the larynx and hypopharynx during inspiration and partly so during expiration. He likens it to an obstructive sleep apnea, which is due to both fluid dynamics and a lack of coordination of inspiratory muscles. Johnson notes breathing is inhibited by several things. Firstly, there are the hormonal inhibitors, and prostaglandin, which is produced by the placenta and membranes, increases about 48 hours prior to labour onset in the term pregnancy, and fetal breathing is thought to decrease because of this rise in PGE2s. Endorphins excreted by the fetal brain and adenosine or adenosine excreted by the placenta also help inhibit breathing. Adenosine is an inhibitory neurotransmitter which is believed to play a role in promoting sleep and suppressing arousal. While Johnson itemizes progesterone and estrogen as hormonal influences, he doesn't elaborate on this further. This inhibition to breathing can be overridden by chronic changes in the hormonal state or by drugs. Johnson describes ambient temperature and humidity as powerful determinants of effective breathing in the newborn. The baby senses temperature change through the trigeminal and vagal nerves as he is being born, and a change of only 1 to 2 degrees can be the difference between inhibition or stimulation of breathing. The unborn baby is dependent on his mother for temperature control. Excessive heat goes from the fetus to the woman via the umbilical cord circulation, so any overheating of the mother would overheat the unborn baby. Behavioral thermogenesis occurs with warming or cooling of the exterior of the unborn baby. Warming can give rise to panting and rapid breathing, while cooling causes shivering and breathing. But with cooling, non-shivering thermogenesis, as with brown fat metabolism, continues to be actively inhibited, and the unborn baby can be limited in its ability to lose heat, and which could be hazardous. Johnson notes metabolism and temperature control are key factors in breathing control after birth. Another inhibitor of breathing in utero is acute hypoxia. Another inhibitor of breathing in utero is acute hypoxia. This is a normal state during each contraction. In a physiological and unmedicated labour, this hypoxia would readily be corrected as such when each contraction is passed. But when hypoxia is severe and prolonged, it will cause the unborn baby to gasp. The last inhibitors are the airway chemoreceptors. The entrance to the larynx has more taste buds than the whole of the tongue. It's absolutely bristling in chemoreceptors. Water and liquor are very different states, and water will be swallowed, not breathed in like liquor or other physiological solutions. Water in the larynx causes the diving response, complete with apnea, swallowing, arousal, bradycardia, and hypertension. Blood is redistributed to the heart, the brain, and the adrenal glands as part of the defense response, and don't forget that beta blockers will blunt the diving reflex. The movie clip, The Diving Reflex, shows this in action with older babies. Unborn babies know their own environment and their own body fluids. There will be no apnea or diving response to physiological saline, amniotic fluid, lung fluid, gastric fluid, blood and milk from the same species. It is important to remember that water, foreign milks and alkalis cause apnea. Just as a follow-up for you later on, in his second paper in 1996, which I've called 1996B, Johnson mentions how babies swallow and breathe differently when fed cow's milk. So the key messages that Johnson's papers give us are, firstly, that with spontaneous onset of labour, no drugs, born with an intact cord into warm, fresh water and no asphyxia, there will be an inhibition for the baby to breathe immediately. Secondly, that surfacing into cooler, drier air and cord clamping will stimulate the baby to breathe. And thirdly, being born into fresh water initiates a diving reflex, so breathing is inhibited. I would suggest that you become very familiar with this paper of Paul Johnson's, because the question, "the baby won't drown, will he?" is a question often asked, particularly by fathers. Considering what I have discussed in the previous slide, particularly with reference to the effect of cooling over the faces with surfacing, it is important to bring baby to the surface in a way which will help him to clear his airways. The photograph on the left shows a baby who is likely to take a big gasp rather than have a cough when his face surfaces. The baby who is held more upright or on his side, as in the photos on the right, will have had the opportunity to drain his airway with a cough before the first large inspiration. This photograph of the baby with eyes shut, pursed lips and not breathing is a common sight in the first minute that a baby surfaces from under the water. The Apgar scoring is usually started at 1 minute of age with a land birth, but many people experienced with water birthing will wait an additional minute before doing the Apgar score. However, we are busy looking at the baby's tone, his colour, and checking his cord rate if we have any concerns about him at an earlier point. One of the things that can fool us in relation to colour is the baby who has lots of superficial bruising on his face, as can happen with rapid birthing. Bruising can be readily differentiated from hypoxia by looking at the rest of the baby's colour, as with his chest or his lips. But of course the grimace we see in these photos tell us lots about a good transition to air breathing. Cord avulsion is one of those things which comes up frequently in protocols and guidelines. There are various case reports on it, but Nutter's analysis gets the potential for this problem into perspective. Less than 0.25% or 2.4 per 1,000 births. There is not enough data available to definitely compare this with land birthing. What data there is shows the risk of cord avulsion during water birth is statistically insignificant. It is, however, important that whoever catches the baby raises him gently to the surface rather than as a sea-to-surface missile with all the thrust that that term suggests. An intact cord should also be affirmed if there has been a cord around the neck. It would be good to think that umbilical cords were no longer being cut prior to babies having fully transitioned to being air-breathing, but I know this is not happening universally. Judith Mercer suggests that with a cord around the neck, the shoulders should be controlled and delivered, and then the head should be flexed so that the face of the baby is pushed towards the maternal thigh. She keeps the head next to the perineum while the baby somersaults out. I have found that babies will do this automatically and really need delivery or assistance to do so. You may be able to see the minimal assistance the midwife gives during the birth in the movie clip LOV, I think it's pronounced. It is very important to remember that if someone other than the woman is raising the baby to the surface, it is vital that he goes straight into the mother's arms, without the wiping of the face, the suctioning of the mouth and nose, or any of the other unnecessary intervention that is so commonly seen on many of the YouTube clips on Waterbirth. You can see the triumph, joy and wonder of birthing in this frame. It is something which needs to be protected, as this is the perfect mix for the beginning of the baby moon, the time when the mother falls deeply in love with her baby. This ends the lecture.